Hello, I'm Dr. Steve Karstensen, Chief Dental Editor of Dental Sleep Practice, a MedMark publication. Welcome to an educational presentation and Q&A about dry mouth and disordered sleep, the overlooked oral systemic link in periodontal care with Drs. Dar Radford and Sarah Ballister. Before we get started, I would like to invite everyone to use the Q&A feature in the control panel to ask any questions. They'll be answered at the end of the session as time permits. After the webinar, we will email all registrants the recording along with instructions on how to access the free CE quiz to receive your certificate. Now I'm pleased to introduce our speakers. Dr. Dar Radford, who in 2009 had the unfortunate experience of falling asleep at the wheel and crashing his car into a tree, got tested for sleep apnea, was diagnosed with mild apnea, which caused the daytime sleepiness, along with many medical conditions that affected the heart and whole body. He was given a CPAP machine, which he could not tolerate. In 2010, when the American Medical Association approved an oral appliance for the treatment of sleep apnea, Dr. Radford jumped at the opportunity and made one for himself, which he wears every night. He has since helped thousands of patients and hundreds of thousands of patients through teaching dentists with snoring and sleep apnea issues. His formulation of RADZZZ is not only helps lower sleep apnea and snoring, it also helps one fall asleep and stay asleep. Also with us is Dr. Sarah Ballister, previously recognized as Sarah Oshman, is a distinguished board-certified periodontist specializing in implant surgery. She proudly represents Millennium Dental and is renowned for her commitment to merging traditional dental principles with cutting-edge technology and contemporary scientific advancements to achieve optimal oral health and stunning smiles. As a periodontist, Dr. Ballister's expertise extends beyond clinical practice. She is listed in multiple professional publications and hosts a dedicated study club. Through this, she mentors clinicians and hygienists, empowering them to surpass professional milestones and provide exceptional patient care. Dr. Ballister's holistic approach and passion for dental excellence defines her as a leader in the field, dedicated to transforming smiles and enhancing overall dental wellness. So thank you guys for joining us, Dr. Radford, Dr. Ballister. I'll turn it over to you to learn more about today's topic.
Thank you.
Thank you so much. I'm going to go ahead and share our presentation. So today we're presenting on dry mouth and disordered sleep, which is an overlooked oral systemic link in periodontal care. And I'm sure many of you have sat through countless CE or virtual Zoom. So to make this more engaging and more fun for both of us as well as you, we're going to be presenting this as a conversation between the two of us. You get the perspective of a sleep expert and periodontist working together. So I'll turn it over to you, Dr. Radford, for any additions to your introductions or personal stories or anecdotes you'd want to share before we kick off the lecture.
You know, being a sleep apnea dentist, and I never thought of that until I became a patient. And Dr. Carlson, he introduced me as my accident that happened in 2009. But really, at the end of the day, it's not just about the experience that we go through. It's what are our patients going through? Are they suffering from physical illness related to sleep? Are they suffering from mental health relating to sleep? You know, when you look at when I was at a conference at the CDA, I had over 300 people in the audience, and I had them start off by just Googling and searching how many years off your life if you don't treat sleep apnea. And so we're seeing estimating of about 10 to 15 years off your life. And so the passion is there. Within the dental field, we all have that ability to be able to save lives and save relationships and improve the health. But there are some side effects. Sometimes the CPAP machines cause dry mouth, and the oral appliances, if people are mouth breathers, especially because they have deviated septums and turbinates that are, blocking their airway nasally, they may also get dry mouth, and we need to be able to remedy those symptoms. And I'm excited to discuss this with you, Sarah. And I know dry mouth impacts the periodontal health. I mean, after 23 years of being a dentist, it's rampant. It improves when there is saliva flow, less bacteria, right? Less tartar and plaque
Yep.
buildup.
Mhm.
And so I love this 1-2 punch that we're doing. Hopefully we can educate the people here on maybe adding a service or services to their practice, but ultimately improving the patient care. And let's have some fun with it.
Yeah, I'm really excited to dive in and really point out some new connections and have everyone look at things from a new perspective. Sleep, dentistry, and periodontics may not immediately come to mind as something that relates and plays off of each other, but when we look at the whole patient and we look at holistic care, there's definitely a lot of interplay. So I'm new to the sleep dentistry field, and I was really grateful to meet you and really be able to dive into and learn more about it. But I'll ask the first question that came to mind for me looking at sleep dentistry is, isn't sleep disorder just snoring? Why should dentists care?
So snoring is annoying, right? It's annoying for a bed partner. It's annoying for the person sleeping next to you. Their sleep can be affected, but it doesn't necessarily mean that you have sleep apnea. And so sleep apnea is defined by the American Medical Association as the number of apneas and hypopneas you have, which is if you stop breathing for more than 10 seconds, and if you have a hypopnea, which is a decrease in oxygen intake, so a slow oxygen breath that you take that affects your pulse ox on a sleep study by at least 3%, it dips it by at least 3%. Those recordings on a sleep study, the apneas and the hypopneas, determine if you have sleep apnea. I've had patients who snore ridiculously, but they have no apnea.
Oh, I was going to ask that. Is snoring,
Yeah, and snoring is a red flag. And a lot of people don't have bed partners. They don't know. They've been told maybe on a camping trip or maybe in a hotel room, staying with family. But there are apps now out there. One of them, my favorite one, Snore Lab. So that's one that you can download and record yourself. And you can see if there's snoring involved. And snoring is a kind of red flag. I'm going to mention red flags a lot. That you should get a home sleep study. Because it could be that you may have those apneatic or hypopnea events, which could lead to a slew of medical conditions and dental conditions that need to be treated. So if it's not treated, we've got all these higher risks of systemic disease, including shorter lifespan. And Sarah, I ask you, what's it worth to add, let's call it a decade to someone's life, right? Or University of Wisconsin showed 5 times higher risk of cancer of any kind. What's it worth to a practitioner, a dentist, to be able to identify this by screening a patient, ultimately getting them treated with a CPAP or an oral appliance, depending on the severity of the condition and what the patient can tolerate. And so that's, I know you do some beautiful work in perio. We know perio and cardiology and heart issues and I think it's also been linked to Alzheimer's and dementia. If you have gum disease, all these systemic things, diabetes type 2, increasing diabetes risk factors. So those also, perio also leads to these kinds of shorter lifespans, but sleep apnea can really affect so many different inflammations and cardiovascular disease and memory loss and also Alzheimer's and dementia. The correlation, it's been estimated about 13 different medical conditions are severely contributed or added because of sleep apnea. It just makes it a lot worse.
Yeah, there's a lot of systemic links both ways. I would, venture to guess if any of the dentists listening in or any of us asked ourselves, do we have the ability to add a decade to somebody's life? Many of them would say, no, I do fillings and I clean teeth. But if you're screening for things like sleep apnea in your practice, you have that ability, and you have that ability to reduce people's cancer risk. So I think there's a lot more that we can do as providers when we really just take a step back and see what we're capable of.
So, sometimes, Sarah, we always wonder, what are some of the oral signs, right? What are the red flags or the things that we look at when we look at gum disease, right? When we look at enamel being worn down, bruxism, when we look at some of the different red flags dentally and even medically, but within the mouth, you and I could look in there and we can go through a bunch of things that can show indications of possible sleep apnea or sleep disordered breathing. And so you don't have to just look at the medical history. We were talking about those cancer risks and heart attack and stroke.
Mhm.
Before you even go in the operatory, Sarah, you could look at the medical history. You haven't even seen the mouth yet. And if you see those medical conditions already existing, right? So some of those things like high blood pressure, again, history of heart attack, history of cancer. You see, oh, 2017, patient had prostate cancer or breast cancer, and now they're in remission. Okay, they're probably taking medications that affects some sort of saliva flow. That's what we look at. But how about we ask them how well they sleep at night? And they may reject. They say, oh, yeah, I sleep great. No problem. And if you ever in the future have any sleep issues, you notice that you get up tired throughout the day, or someone told you that you snore, there's ways of testing that now with a home sleep study. If you ever need the help, let me know. And that's it. You're looking at the medical and you're reverse engineering, but now you can look at the mouth.
I think a lot of providers, and some of the hesitation we have is, so we identify these problems, right? We see the bruxism, we see the mouth breathing, we see the jaw tension, but like, what are the next steps? It seems very overwhelming to recommend someone for a sleep study. Can you kind of walk through the simplicity of that process so people feel more comfortable? Like, if you don't know what the next step is, you're not going to screen. And they taught us, don't take biopsies to check for oral cancer, or don't biopsy something unless you know what you're going to do next if you get a positive result for that. So if we screen our patient for this and we see these problems, what are next steps that you recommend?
So if you're seeing lower anterior wear, bruxism, if you're seeing possible mouth breathing because there's lots of tartar buildup on those lower anteriors, and if you see TMJ issues or bruxism issues that are causing tightness of the jaw, trismus, popping and clicking, there's a lot of that's related to the patient struggling for air, right, in the middle of the night. And so to bring it up to the patient, it's a simple question. How well do you sleep at night? Do you feel tired throughout the day? What is our fear in our mind that prevents us from asking such a simple question? Is it because we're worried that the patient thinks we're trying to sell them something new and they're paying for our car that's parked in a parking lot, or for the next vacation that they know that they've asked us if we're taking a vacation and, oh yeah, we're going to Italy. Oh, doc, are you doing this crown to pay for your trip? I mean, we've all heard these sarcastic remarks. So what happens as people pleasers, and we are that because we are looking for recurrent patients, that they don't just come one time. Most of the time they come every 3, 4, or 6 months. We don't want to scare them off. But if we let those limiting beliefs aside, push those limiting beliefs aside as a practitioner, and just look at the facts that we see that can be correlated to sleep disordered breathing or sleep apnea, that can have a slew of those medical issues, and we have the courage to bring it up, the next step is really simply, I see this, it could be related to sleep, and these dental conditions and these medical conditions. Please either see your physician and see if you can get referred for a home sleep study. And let it go. And that's it. That's if you don't want to do it. But at least at a minimum, Sarah, we've looked in the mouth, right? We've seen the red flags, some of these that are listed here on the slides, of jaw issues and mouth breathing and xerostomia and whatnot. And large scallop tongue is another big one, right? Class 5 lesions because of the acid coming up, dentin exposure. Sure, they're not only the result of sleep apnea, but it's a major contributing factor to these dental conditions. And so what we can do is just hand it off and tell them, hey, I see this just the same way I see any sort of condition that could be related to a medical condition, and you hand it off to send it to an oral surgeon for a biopsy, right? And let them handle it, or you send it to ortho for expansion on a child, for example, or a teenager, and let them handle it. If you don't do ortho, if you don't do biopsies, and this is the same thing, you can hand it off to a sleep physician. I would find someone in your neighborhood that you see their facility. meet a couple sleep physicians, say, look, I'm screening for this now, and just do a direct referral, hand the business cards over, just like you do any other type of service that you don't provide within your practice.
Yeah, that's a really great idea to connect with someone locally to do sleep studies and pass that on. I think bringing it up conversationally and showing that you noticed really does build that connection with the patient. And especially if you're not doing an immediate sale. And I understand the hesitation when we want to recommend something to someone and then it leads to something immediately. Like, for example, I see demineralization. I'm going to recommend a fluoride varnish. Oh, by the way, that costs X amount. And that's where we get that hesitation. Starting those conversations and having a workflow where you can refer out for a sleep study or refer out for care or do that care in partnership is really, really great advice. So I know you mentioned some of the local factors, but what are some of the biggest systemic risks that we see if sleep isn't treated? So your patient says, yes, I'm having trouble sleeping, but who cares? Why should I bother looking into this?
Yeah, the biggest one is cardiovascular issues. And, I jumped into the cardiovascular problem when I had my arrhythmias. And I had a patient recently come in, and she's had a mild heart attack. She's also had a history of cancer. And I asked her, I said, how well do you sleep? And she's like, I sleep horribly. I wake up every couple hours to go to the restroom. And I'm grumpy in the morning. I'm depressed. I'm on antidepressants. And these are systemic mental health issues, systemic cardiovascular issues, your mood. And there's links to hormone imbalance, lower levels of growth hormone and testosterone, including cortisol, high levels of cortisol, and low levels of leptin production, which means you gain weight by not sleeping well. And so there's a lot of risk factors here. And she said something to me. She said, why didn't my physician that treated me for, my heart attack refer me for a home sleep study? Why didn't my oncologist, if it's such a high risk? And, I've talked to physicians in the past, and they're very focused on treating cancer. If it's an oncologist, they're very focused on treating the high blood pressure, the heart issues, if they're a cardiologist. And the sleep physicians are treating the sleep. So they don't like to really cross-contaminate the professions. It's not like in dentistry where I'm looking at perio. I could tell if they need to go to you. I could tell if they need to go to the ortho. It's a different brain and genre of health in dentistry, because we can plug and play the different specialties within dentistry. And medicine doesn't necessarily come out that way unless the patient themselves tells their cardiologist, yeah, by the way, I sleep really, really poorly. And so these systemic diseases, let's call it 9 different medical professions: cardiology, urology, because of frequent nighttime urination and erectile dysfunction being correlated to sleep, endocrinology for diabetes, gastro for acid reflux issues, oncology, internal medicine. They all work separately. So, it behooves us to be able to look at these, explain to the patient that they do just focus really on that. And at the end of the day, just again, I train my dentists, my clients that take my coaching program and my training program. They can do this themselves. You could refer for a home sleep study, which we already have set up. We've got hundreds of doctors that dentists that refer for the home sleep study themselves, and have the patient get diagnosed by a board-certified sleep physician, get the results, and go, hey, Sarah, we were right. You're not sleeping well. And it could be the reason why you have these medical conditions. You got the mouthpiece, you got the CPAP machine, and you got surgery. Go over those 3 treatment options and what's best for them, so that you can ultimately help lower those systemic diseases and risks.
Yeah, it's really, really all tied together. And medicine is so siloed. I mean, look at the silos between dentistry and medicine itself. Like, we speak to our medical colleagues and they don't look in patients' mouths. And I'm hoping that, as we move forward and continue to have these conversations, that this reaches all fields and we learn to kind of break down those silos. But it's got to start somewhere, and it's wonderful that it's starting in dentistry, and it's wonderful that it's starting here.
For you, Sarah, when you have a patient and they do have, let's say, sleep disorder, or they're wearing a mask, right? There's a lot of air being pushed down their throat.
Mhm.
How have you seen the effects of mouth breathing? We talk about mouth taping. You can't mouth tape and close your mouth and breathe through your nose if you can't breathe through your nose very well, right?
Right.
So
Yeah.
what have you seen with the CPAP, the oral appliance, and the mouth breathing? What's that doing to the periodontal health?
So there's definitely a large link between dry mouth and periodontal disease that we see, just as there's a link between caries and dry mouth. So, working in clinical practice and, bopping over to check our hygiene patients and have those conversations and see patients over time, which is what you brought up. And it's one of the things I love about being a periodontist is I get to see my patients every 3 months more than their physicians that see them for their annual physical. So, I may see a patient and see some changes that I didn't see there before. Like, for example, even yesterday, I had a patient who now is getting cervical caries. And I asked her, what's going on? She's like, oh, I switched my medication. I'm now taking this antidepressant and I'm getting a lot of dryness, and I started sucking on candies, and maybe that's why. And I'm like, well, do you hold it somewhere? And she holds the lozenge in her mouth in the area, and we now have 2 new cervical lesions. And getting to recognize these things is, very interesting. So I want to just take the time to mention we are CE, so we've got to put out some facts. So, medications do cause 90% of xerostomia, and 32 million adults take 1 or more medications every day. I also want to share, when we're looking at that med history and we see the number of medications a patient's on, that impacts their risk for dry mouth. So just think about in general, 1 in 4 adults is at risk for dry mouth, and the risk increased with an increase in number of medications. I'm going to share one of my favorite statistics is 17% risk for dry mouth if you're not taking medications. That bumps up to about 34% if you're taking 3 or more medications, and 67% with 7 or more. So you were sharing about a patient who is taking all these different medications, seeing all these different specialists in silos, and not being able to sleep. So all of those are huge red flags that we need to be looking at. So when we have those red flags, and then we look in the patient's mouth and we see they're suffering from xerostomia, dry mouth, like objectively, we can see they have reduced salivary flow, or subjectively, they have a feeling of dryness. We know there's going to be kind of a pathogenic biofilm shift, right? So all of those nasty gram-negative bugs, all of those things that cause periodontal disease are going to finally have a home that they love, which is, the bane of my existence. I want them to hate being there. Other things with sleep is, if you're not sleeping well, you have those hormonal imbalances, you're going to have worsened inflammation, more inflammation, more perio progression, impaired healing around anything that I'm doing if our patients aren't sleeping well. So it's this compounding cycle of hormonal shifts, increased susceptibility to inflammation. And it's something you wouldn't really think about to even ask. One of the things that also we struggle with is just doing surgery on someone who's then wearing a forced airway device. And then you have to really understand what are the impacts, and is that patient the right candidate? Because what are the impacts of them when wearing forced airway or an oral appliance recovering from surgery? And then what's the implication of if they don't? So if they stop wearing that device to allow for healing, are they going to heal well because they're not sleeping? So you really have to look at the patients holistically. And that's something, I want to throw back to you. If we had a patient who needs to wear the CPAP to have good sleep and good healing, would that make them a candidate for something like aesthetic gum grafting if it meant they wouldn't be able to wear their CPAP for that time?
I go back to these patients that lose their appliance, or they leave it in a hotel room, and then they freak out and come to my office and they're like, "Doc, I lost it. Can we get another one?" And we have a scan on file, and typically we just hit the send button, and they're like, "When is it going to be here? Tomorrow?" I'm like, "Well, it takes a couple weeks." and they freak out because they don't want to be without it for 2 weeks, because they know how they feel the difference between wearing it and not wearing it. They've tested it. They've fallen asleep on the couch and woken up at 3 a.m. and gasped and not felt right the next day, compared to the weeks, months, years of them just wearing an oral appliance. And so surgical implications when you do surgical things in dentistry that may be able to wear that appliance can affect, obviously, their well-being. It's almost like, what's most important? Is it the sleep, or is it the dental condition? Of course, we are trained as dentists to provide as the best care possible for them to have a healthy oral dentition. And I think that the times where I've had patients go through surgery, they've had to not wear their appliance for a couple of weeks, and that's when they're diving into, sleeping at a 45-degree angle just so that they don't have their tongue fall back if they're sleeping more supine or flat. That's when they're, for sure not eating late, not having coffee or energy drinks too late, making sure that I actually give them, they take my sleep supplement, RADZs. That helps. There's an ingredient in there that I want everyone to start looking at. We're so based on pharmaceuticals, but there's a natural ingredient called N-acetylcysteine, NAC. And NAC, if you just Google NAC and sleep apnea, you'll see NIH.gov studies that have showed lowering of apnea just by that ingredient alone. And so there are certain things, and I've had patients test it. They've seen their sleep improve by about 30% when their appliance is, being fixed, or they need a new one, and they can't wear it, and they take the supplement. And so there are certain remedies to be able to help reduce the apneic events so that the body is in a place where it can heal quicker and faster, and it's not going through these stressful inflammation kind of, situations. But, you mentioned something about your patient. You said that she's gotten cervical caries because of the new medication of the antidepressant. Okay, so let's reverse that again. Not all patients that are antidepressants are as a result of sleep apnea, but it's estimated that up to 30% of patients with depression, clinically diagnosed depression, therefore their recommended medication, is as a result of sleep apnea. And so that's why you look at that medical history, you see the cervical caries right away. It's like, okay, you're taking this medication. How's your sleep, by the way? Do you feel like you get a good night's sleep? Because we've noticed that not sleeping well affects our serotonin levels, and we have a hard time with symptoms of depression. Have you ever been tested with a home sleep study? And that is the conversation. Because imagine if there's a possibility, just a small possibility, which clinically they've shown, that if you incorporated the CPAP or an oral appliance, depending on the severity of the sleep study, the disease, that they could be off that medication. And now they're not using the sugary lozenge or the candy. And then now you've got more saliva flow back, and now you've got less periodontal disease. So you just went from going about a sleep conversation to a possibility, a distinctive percentage possibility of the patient not having to be on that one prescription medication. That's very powerful.
Yeah, it's really taking it back, taking the concept back to the root cause of the disease. And we were just discussing that each type of doctor only wants to do their one thing. So if we just look at that patient and say, okay, I'm a dentist, I'll fill the cavities, and we don't talk about her dry mouth, that's one step, closer to what's the cause. And then we don't talk about her medications, and then we don't maybe have that conversation about what's causing it, and we don't talk about her sleep. We're just scratching the surface and never really getting down to the root cause. One thing, you keep talking about oral appliances versus CPAP, and I can imagine how difficult it is to have a restful night's sleep with a mask or an appliance in your mouth when so many people need things just so when they're sleeping. Can you share why so many patients give up on CPAP and oral appliances, and what are some of the differences between those two options?
Yeah, so the biggest problem with CPAP is claustrophobia. People, when they put it on, they feel like, anxious, and it's very hard to wear throughout the night. A lot of times it's hard to keep clean as well and travel with. And it's a little bit of an embarrassment putting it on, next to a new bed partner. You can definitely say, oh, I'm not snoring if I put this on, but at the end of the day, it's embarrassing to bring that up because they look at you like, wow, what is this thing that you have to wear? And the noise from it can keep them up and all these things. So that is really the negative impact of CPAP and the tolerance to it or the compliance. The percentages are very low. And so a lot of patients try it and then they're stuck with nothing. And they're like, I'd rather die than wear this thing. And so, oral appliance therapy is not for everyone. The CPAP can be used for even the mildest or the most severe cases, depending on how much airflow could be pushed through. But oral appliances really do help with mild to moderate cases. I actually had a patient just this week. I posted it on my social media, just the sleep results. He had 34.2 episodes per hour. And with the oral appliance, after 3 adjustments, we got him down to 2.8. That was one of the biggest differences from, the beginning stages of severe down to really no sleep apnea or under 5 is considered a healthy situation. And so that was just with an oral appliance. So even though the patient's severe and they should be on CPAP, and oral appliances are best fit for mild to moderate patients, that doesn't mean that we should not treat as dentists the CPAP non-compliant ones, whether they're mild, moderate, or severe. So I also had a patient, he had 68 times an hour. He couldn't tolerate the CPAP. It was very uncomfortable. The air was drying him up too much, the air pressure. So I told him, he said it was like sticking his head out the window, driving about 60 miles an hour and feeling the air hit his face. It's just uncomfortable.
Oh my goodness.
Right. And we tried to do the combination of an oral appliance and dial it down. It was still because you could, not have as much air pressure if you have an oral appliance holding the jaw in a certain position. But we brought him down from 68 down to a 31. And he felt like, I was his savior because he felt so different. So it was better than nothing. So there are positives and negatives for both. I would say the oral appliance, you can see some jaw and bite shifting happen. I definitely use a morning aligner for every patient to mitigate those. The cleaning of the oral appliance, mine is the sleep herps that I wear for the last 15 plus years is really easy. I clean it with a little spray that I have and a lot easier to travel with. And more importantly, Sarah, if there's a bed partner in and you're just sliding this in your mouth, it's more discreet and less embarrassing.
I definitely see that. You did mention the forced air and dryness before we move on to talk about some management options that I use as a periodontist. Can you share, are patients with oral appliances going to be at risk for dry mouth due to lip incompetence? Is it only CPAP users? Should we be screening all our CPAP users for dry mouth? What's with those water tanks? Can we just talk a little bit more about those things?
Yeah, definitely. I've had some patients use humidifiers to help in the room, with their dryness. But the CPAP definitely is the more of a dry mouth inducer. The oral appliance, I've had it both. I've had patients tell me, "Man, I'm drooling like crazy now. What do I do about this?" Because it's stimulating their salivary glands.
Yeah.
That with respect to their cheek muscles kind of overworking, we see that happening. But then we also see if they are a mouth breather and they can't breathe through their nose and they have an oral appliance in, you're going to see some xerostomia. So that we need some remedies that we'll go over together. Mouth taping or wearing a chin strap with the oral appliance in. The sleep herps has some rubber bands that you could hook on to keep the mouth closed, will help with the dryness. But Sarah, if you have a deviated septum, if you have turbinates that are inflamed, sinus issues, congestion issues that are chronic, you're not going to breathe through your nose. When you mouth tape, you chin strap, you do all that, you're going to need to be able to have that mouth open and breathe in through your mouth. And now when you're getting more air going in, the back of the throat definitely feels a little bit more dry. So ENT physicians have been really important in managing their nasal passages or having that evaluated to see if they need to do some sort of surgical intervention to be able to make them and allow them to become nasal breathers.
Yeah. there's a lot to digest, but I heard some red flags and I just want to touch on them again. As a listener, I love when the key red flags that I can look out in my patients. So if we see our patients are CPAP users, we're going to definitely want to screen them for dry mouth. If they are using an oral sleep appliance, we definitely want to ask them questions. It could go either way. We could have a drooler or someone who's super dry on our hands. And then also let's recall back to that original red flag. If we're seeing that this patient is on medication and our risk for dry mouth is going to increase with all of those medications. I want to talk about some options. So we talked about my patient who loved to use sugar lozenges to help dry mouth. That's not a great option. So if we're going to do lozenges, or gums, we're going to want to start with sugar-free gums or sugar-free lozenges. And the most basic first step, if you are dry, we need to be hydrating. So step one is always drink more water, use more water. We can get a humidifier going in the room. Sometimes that's not enough for our patients. So we can move towards the next step when just staying more hydrated or chewing sugar-free gums is not enough. And that's going to be our over-the-counter rinses. And those are often water-based. And this is why they're in the middle. They can be short-lived. So we're talking about someone who's sleeping through the night experiencing dryness. So it may not be enough for our patients with more moderate or severe xerostomia or oral dryness from that mouth breathing, because those water-based solutions can quickly evaporate and be short-lived. So we can move into a more long-lasting option for these patients, which are our lipid-based solutions. So we can do lipid-based sprays that can put a hydrophobic layer of protection for our patients, and those have a longer lasting effect. Think of this as the difference between having chapped lips and just putting some water on or licking your lips versus some chapstick that's going to seal in and retain that moisture. In our really severe cases, let's say we've got our patients who may have Sjogren's and disordered sleep, or really, really severe dry mouth, we can move to systemic medications. I do have a slide up here. There is a lot of text, and I know this is a fun conversation. So for those of us watching, you might want to screenshot. It just goes through the product categories and what their benefits are, frequency of use, and long lasting. So looking at our oral rinses, mouth rinses, what our main ingredients are, water, how often we'd have to use them, 5 times a day, oral sprays that are water-based. Really got to watch these. Some of these, if you look at the instructions, can be up to 60 times per day if a patient is severe, and we got to move them off of that because some of these things have ingredients that we don't want to be consuming that much of. We have oral gels, powder rinses, and then we've got our systemic salivary stimulants. Those we want to work in partnership with our patients' physicians, but know that those do have side effects. So if you're going to increase the stimulation of the salivary gland, you're going to have more sweating, more urination. And then some patients aren't, candidates for things like pilocarpine because they're already taking the opposite, like someone who's an asthmatic patient can't take something like that because the two medications are working in opposite directions. And then we have a prescription strength oral spray that's lipid-based. It's a pump spray that can be used 3 to 4 times a day to retain moisture. So there's lots of options going from drinking more water all the way to systemic medications and a whole depth and breadth in between. We just need to have these conversations with our patients and meet them where they are. I want to share 2 studies that do a little bit of comparison of these products. So we all can screenshot or refer back to our different options. But these are studies conducted by 3M researchers measuring moisture loss over time. And these studies demonstrated significantly less water loss over time using a lipid-based oxygenated glycerol triester technology using a lipid-based spray. So we can see our control of water, aqueous water-based spray, water-based rinse, and water-based gels. And then over here in the pink, we have the OGT lipid-based spray, and we can see the percent water loss after 4 hours is significantly less for a lipid-based spray. So if we're looking to provide comfort for someone and retain moisture through the duration of sleep or through the duration of a day, something that seals in that moisture is really going to be advantageous for them. So they don't have to wake up and reapply. One more thing I wanted to just touch on is there's a difference in the lubricity provided by these different products. So if you think of coefficient of friction, right? So something like rubbing your hand across sandpaper is going to have a really high coefficient of friction versus like running it down a slide, something that's very slick. So in this study, we're comparing lubricity and coefficient of friction, and we see the reduction in the coefficient of friction is much more when we're looking at using something that's lipid-based versus water-based. So using it as a lubricant, you're going to have a lot more comfort, especially though with like a bulky oral appliance or removable appliances. I definitely think about lubricity with my All-on-X patients and that prosthetics that they're wearing and getting used to. So I love just having an understanding of what we're recommending. I feel like in dental school, we weren't taught a lot of options for dry mouth, and we didn't really have these conversations. So they're like, oh, just send your patient to CVS and have them get a water-based rinse. Like, there's so many more options than that. But I want to just circle back because I can't take over and talk too much and ask, what kind of feedback do you get from your patients once you address their dry mouth? And does it help with compliance?
You know, I had a patient yesterday who has really large mandibular tori, and she feels like when she drinks wine, now her mouth even dries up even faster. And we all know alcohol kind of dries everything up, right? So you got your wine drinkers there, or your alcohol drinkers on a nightly basis that get super dry. And it's not just the systemic medication or the medications for the systemic issues or diseases that people are taking, or just the CPAP or even oral appliance. And one of the things that I've had patients try is coconut oil. Before they go to bed, they swish around for about 5 minutes if they can, up to 5 minutes with coconut oil. Of course, we've had biotin as something I remember from dental school days 25 plus years ago. That there was a conversation about using biotin, but a lot of patients tell me it works for like 30 minutes and that's about it. And so I have seen a significant improvement if the patient's doing their 2 to 3 liters of water a day. So water intake does help tremendously. A lot of these patients and I tell them, don't drink the water within 2 hours before bedtime. You're going to get up and go to the
Yeah, that's not going to work.
Really the most success I've seen is with Aquoral, and that's been the best that I've seen patients use, including my mom. She was my first patient that started using it, and she's on medications due to her history of cancer and cholesterol so she does take some medications that have really significantly dried her mouth up, that now she's a 3-month perio patient. And even when she comes in 24 and 25 on the lingual, there's always tartar. And she flosses 2-3 times a day. She brushes, at least 2 times a day, if not 3 times a day. She does try to drink as much water as possible. But definitely the Aquoral spray has done wonders for her. I would say she says she uses it somewhere between 2 to 3 times a day.
Awesome. And to clarify, that's the lipid-based OGT spray.
Yeah.
Awesome.
Yeah. And the other thing that I've noticed patients doing is chewing a lot of gum. And sure, they do sugar-free gum, and I chew gum because of my salivary flow, and it's helps stimulate it. And then obviously what happens is they get TMJ issues because they're exercising the masseter a little too much, and they're crunching and grinding 500 times every time they chew. And then so that's giving TMD. So, it's a give and take here. So we got to be careful with those, the gum chewing as well.
Yeah, I wanted to ask you, like, what's the bigger impact, like, on your patients' lives when you treat both their sleep and their dry mouth together? What kind of changes? Can you share some stories of some success stories? Can we end with some, warm fuzzies?
Yeah, just to be able to taste your food. I think that's a huge thing for these dry mouth patients. They complain about not being able to taste certain foods like they used to. As the people listening here, if you're not going through it, you don't know how horrible it is to not be able to have the same taste as before. I remember during COVID, if you all lost your taste buds, I
Yeah.
was putting hot sauce on my Chinese food, the most flavorful thing I could eat during the time I had COVID, and still was like, I can't taste anything. It was horrible. Like, what's the point? What's the point of having a chocolate cake or ice cream or some of the fun things in life if you can't taste your food, right? So that's huge. I mean, you're improving that quality. I don't want to get too personal or whatnot, but relationships can be affected with low saliva flow. I had a patient in her 60s. She was telling me that she can't, kiss the same way. So there's a lot of intimacy implications, that there may not be sharing with us because it's an embarrassment for them. And then, of course, the sleep is just, after treating over 3,000 patients now with oral appliances and a bunch more that went off for CPAP machines, and they come back and they tell me how the number one thing is, man, you saved my relationship. You saved my confidence in being able to be next to a bed partner. I mean, that is psychological impact that to most people is more important than the dental ramifications you're reducing, the systemic medical ramifications that you're reducing, and then the fact that they have their quote unquote, I now have more energy to be able to, like, after I come home from work, to hang out with my kids or to go to the gym. This is what they care about. This is the powerful impact we have to be able to treat sleep. Sure, the cardiovascular, the cancer risk, and those things are much more important. But Sarah, the fact that they sleep in the bedroom next to each other and they're not in sleep divorce, which is a thing now, about a third of bed partners that sleep under the same room or in the same house sleep in different rooms if they snore. And so that affects, intimacy as well. So there's a big sociological or emotional impact that you have on your patients when you treat sleep and when you help them with their saliva flow.
Yeah, it's a really great service to do. And I mean, I love to see it because there's better perio outcomes when we're having more moisture in our mouth, and happier patients come back. So I just want to go over a treatment protocol that you can incorporate into your practices. This was published in Oral Health CE and Dr. Bicuspid, and it's to just diagnose. So it's a lot about what we've been speaking about high level this entire conversation. And you can take this and apply it to those sleep screening questions as well. And it's just identifying when your patients are suffering. And here we're identifying when patients are suffering from mild, moderate, or severe xerostomia. And that can be through questionnaires, looking at red flags. You can do this using things like Fishburne tabs, which you stick in a patient's mouth that absorb the saliva through wicking and give an indicator. You can look at a Calicombe scale or just do a chair side evaluation and pull someone's lower lip out. I just want to go over a chair side evaluation for salivary flow really quick. If it takes greater than 60 seconds to see pooling after pulling out a patient's lower lip, that's very low objective salivary flow. 30 to 60 seconds is medium. And if you can pull out the lower lip and see beading of saliva in less than 30 seconds, that's a high salivary flow. So you just want to diagnose and screen. You want to educate. So that's the same thing as asking patients if they're sleeping well. You want to educate them on the implications of sleep, educate them on the implications of dry mouth, and things that they can do. And then you're going to want to implement something. So for when we're screening for sleep patients, we're going to implement by recommending they go for a sleep study or referring them out. When we're implementing with dry mouth, we're going to go through that list. We're going to start with implementing hydration, water-based sprays. We're going to get feedback from our patients and go in the circle. We're going to implement our lipid-based sprays like a coral, and then get their feedback and make sure we're meeting our patients where they are and getting them that right level of hydration. And obviously follow up with them. So we just keep going through this cycle until we address our patients' needs. And it's the same basics that we look at in medicine. I wanted to leave this up for a little bit. These are some landing pages where you can learn more about a coral, learn more about dry mouth, learn more about sleep specifically. What Dr. Radford's QR code. I also have a QR code which gives a more perio focus. This brings to 2 different landing pages. And for those of us who are going to be using pump sprays, we want to make sure that we shake, prime, spray, and distribute. Oh God, we got one on screen over there.
I got mine here because that helps me with mine. I sometimes get a little dry mouth with my oral appliance, the room temperature.
And if you want to learn more specifically or reach out with questions about a coral, there's contact information here. And I'll close up with some additional references, some of the statistics that we shared throughout the presentation. Hopefully it didn't feel like too educational or dry, but we did reference them. So if you'd like to read more,
Right.
more here.
That was a good pun, Sarah.
That's right. I also want to remind people that are watching the webinar that you're going to get a copy of the recording of the webinar also in your email, so you can rewind it and watch whatever sections you'd like again, over and over again. Because this was really interesting information, guys. Thank you so much for putting this together to be able to give us this insight into, the mix, the overlap, the combination of considering airway and gum health. And that's really, we're the only part of medicine that does that. You guys talked earlier about how people can inquire from their physicians about, well, why is my mouth so dry? And the physicians will be kind of medical centered or pharmacy centered because they prescribed a medicine to treat a symptom or a sign of some other disease, and they may not have considered the downstream ramifications, or they think they're just, you got to live with that. So when somebody comes to you and says, well, God, this medicine's making my mouth so dry, how do you handle that? Because you kind of don't want to throw the physician, shade on that one, but you can't take them off the medication. So tell me how you handle that conversation.
I can grab that one because we're going to go through our options first. So obviously starting with inquiring about their general hydration, incorporating water, recommending water-based sprays, moving up to lipid-based sprays. And if we're still struggling or unable to manage, referring them back to that physician to have the conversation. Is there something else? We see the same thing with gingival hyperplasia from hypertension medications. So, first we say, is there another option we can use? Because this patient is really experiencing this side effect. And if not, if that's the only thing that's controlling their blood pressure, we just manage it together with repeated gingivectomy, or you manage if that patient cannot come off that antidepressant or cannot come off that specific medication, we just manage it together the best we can.
Yeah, and I go back to, why are they on this medication? Is there a possibility that, even the smallest possibility, that it's associated with sleep disordered breathing, and dive into that. So maybe if we can fix that, they may possibly get off that medication naturally through their physician, not through myself. But I communicate that with the physicians. Whenever we treat anyone with oral appliance therapy ultimately, or refer them to CPAP, I send them all their MDs a letter letting them know what we've done, and there may be some adjustments that need to be made towards the treatment that the physician's giving to the patient.
Because we know that many of the physicians are poorly trained in sleep issues and sleep breathing issues. So when they see us and we start to connect some dots, it can really make a big difference for people who, they haven't been previously even screened for that.
And when you communicate that with the physicians in your neighborhood, they start noticing your name a little bit more, and what you're doing, and that it opens up, as dentists, a huge source of a referral base, and really a good feeling of wow, I'm working with a network of physicians now that I'm communicating, and they're communicating back, and possibly referring, and vice versa. And so I've got a nice dozen doctors in my neighborhood in Thousand Oaks, California, that we constantly communicate and refer to each other. They refer me non-compliant CPAP patients that they've talked to, and they're like, oh, I can't wear my CPAP. It's the cardiologist, it's the urologist. So as dentists, you can really have a huge impact in your community because you'll get referrals from these MDs because you've been communicating with them about your existing patients and what you're doing with their dry mouth or with their sleep issues.
Now, is a Quirl is a prescription item, and so can we prescribe that, or do you ever get the physicians to prescribe it for better coverage? Or talk a little bit about that, guys.
For a Coral, you can prescribe through an online pharmacy. The QR codes that were under both of our names will link to a page with more information on that. I personally carry it in office for in-office distribution for patients. So there's a lot of options.
I do the same. I have it in the office and ready to give to patients. If I already know they have dry mouth issues and I'm giving them an oral appliance, I include it. It's part of the program, so to speak, in my office, just to make sure I don't exasperate the dry mouth even more after the oral appliance is given to them.
Do you try and get that covered under a medical benefits policy at all?
There are some Cadillac plans that are offering coverage, and patients can also take advantage of HSAs or FSAs, especially for doing in-office distribution.
Okay. Hey, so there's a question about microbiomes and oral health, because we're hearing a lot about microbiomes and how do we influence that and how do we work with the microbiome to increase periodontal health. So does the lipid-based product have any effect on the microbiome, on the pellicle, taste, the nitric oxide production, those kind of things?
So just looking at it from the 10,000 foot view, right? So we talked about coefficient of friction and moisture retention when looking at those two studies, right? So if you think about buildup of pellicle on the tooth and buildup of biofilm, if you're in a moist, slick surface, you're not going to have the ability to just build that up as much. Someone who's very dry and there isn't a lot of flow, you're going to have a lot of buildup. And the more buildup, the deeper that microbiome gets. And the deeper and deeper it gets, you get more diversity. And then you start to get those anaerobic bacteria at the core of that buildup and biofilm, just like you would get those bugs building up in those deeper pockets. And that's where we're getting our most pathogenic bacteria from. So I would say yes, from 10,000 feet, if we're making sure that we've got good lubricity and good moisture in our mouth, we're influencing the biofilm in a positive direction. Obviously, we need to incorporate mechanical debridement, brushing our teeth, involving oral rinses, great diet. You can supplement with probiotics. And there's lots of different ways you can do that through pills, rinses, and sprays that are now offered.
One of the coolest new technologies over the last year and a half I've brought into my office is low-level laser therapy and the impact it has on microbiome, whether you're doing SRPs, you're doing an extraction, implant placement, any area where there's a possibility of higher microbiome. Low-level laser therapy, the company I use is Zirconia. They've helped tremendously with that. They've actually have clinical research to show microbiome reduction with the light that's being used, and it's a cold laser, so it doesn't even hurt, or there's no contraindications. That helps as another tool in our toolbox if we see dry mouth issues and SRPs and yeah, keeping it moist as Sarah said is super important. But I do also add that in there as well.
So it goes to show there's no magic bullet here. Even a high quality material like a Quirl is not going to be something you give a patient, oh, spray this in your mouth and all your problems are solved. It's not like that. Yeah.
Nothing's the magic bullet. We all have to get down to the root cause.
If only, huh?
If
And
only.
so another question is about combinations, and that is, like you mentioned, for example, your patient that has dry mouth is having a lot of carious lesions, and so fluoride varnishes. What about using xylitol-based, chemotherapy, as it were, really, against against the decay-causing bacteria, and along with a coral.
Yeah, I see a lot of success. So I did go through like a flow chart of
Yeah.
water-based to lipid-based to systemic, but you really have to find the right combination sometimes. So when using things in combination, we've seen great success for patients using, for example, like some oral-based, water-based oral rinse and then a coral. The only thing is we got to look at order of operations. You have to think about the lipid-based spray as like a chapstick or a seal. So if you do the coral and then you use a water-based rinse, it's like wearing a raincoat in the shower, which will not work. So you want to make sure that you're doing your water-based rinses, your water-based sprays or treatments first, and then follow that with the coral. Same thing if you want to be using anything that has fluoride or xylitol or any of those sugar alcohols in, if you want those touching the tooth surface and like really touching the pedicle and touching everything, you want to do that first and then do the coral on top. So like a great order of operations would be getting a nice clean mouth. So you want to do your home care routine, use your electric toothbrush, floss, water, whatever you're going to do. And then you want to do your water-based layer. If that includes sugar alcohols or fluoride, that's when you do that. And then follow up with your lipid-based spray to kind of seal, kind of like waxing your car.
Wow, this truly is a thinking person's game here, isn't it?
We got to help patients through this.
So thank you for your everybody for your questions. We run out of time today. I want to give our two speakers big kudos and a last word. Dr. Ballister, what's the last word from you?
My last word is just make sure you're meeting your patients where they are. Whatever you choose to prescribe or recommend, make sure it's something that they can be compliant with and use in their day-to-day.
And Dr. Radford.
We need to reduce the mindset that we can't do this and we can't help because it's too hard or too difficult with respect to sleep, with respect to dry mouth. You guys got some good education today, hopefully, that you can take to your practices. At a minimum, have the conversation about sleep. At minimum, try to recommend these types of products for dry mouth. Be brave. Don't be scared. Don't live in that fear mindset or that scarcity mindset. When you give from your heart, when you truly show the passion that you care about their medical well-being along with their dental well-being, most patients will respond and not push back. And even if they do, tell them, oh, no problem, I'll see you in 6 months, and you treat them then.
That's fantastic. Thank you, guys. So everybody listening, within an hour, we'll send you a link to the recording of this presentation and instructions on how to access the free CE quiz to receive your certificate. Thank you, Dr. Dar Radford, Dr. Sarah Ballister, and our sponsor for this webinar, Aquaro. Thank you all and be well.
Thank you, Dr. Carson. Bye now.
Okay.